Hi, welcome back. I'm Adam Rosen, orthopedic surgeon, and today I'm going to talk to you about Achilles tendons. Achilles tendon injuries from tendinitis all the way up through Achilles tendon ruptures. Now, Achilles is a mythological Greek warrior, and it is said that his mother was holding him by the heel when she dipped him in the river Styx, and that was his vulnerable area. And even us as mere mortals are vulnerable to injury in this area. Now, the Achilles tendon is an incredible tendon. It is the largest and the strongest tendon in the entire body, and it can sustain up to 10 times body weight, but we can still have injuries. We can develop either Achilles tendinitis, a chronic condition called Achilles tendinosis, or an acute traumatic rupture, Achilles tendon rupture, and these are the three things that I'm going to talk to you about today. Okay, so the first thing is Achilles tendinitis. So this is a chronic inflammation of the tendon, inflammation-itis, tendinitis, and typically symptoms are present for about 2 weeks. It'll be worsened by activity. It can be tender to the touch. The second thing that we worry about is something called Achilles tendinosis, and this is more of a chronic condition. So symptoms have been present for more than 2 weeks, usually even more than 6 weeks. It'll still be tender to the touch. The symptoms can wax and wane, but when you look at the tendon or feel the tendon, you'll feel this thickening or this nodular bulbous area in the mid portion of the tendon where the tendon has been diseased. Now, the third injury that we're going to talk about is the Achilles tendon rupture. This is an acute traumatic rupture of the tendon. And when this happens, patients typically hear or feel a pop. And you may have seen football players like Aaron Rodgers tear his Achilles, or the late Kobe Bryant when he tore his Achilles playing basketball. So at any time when we push off hard or come down onto a plantar flex foot, the forces on the tendon can be so great that the tendon actually ruptures. And patients feel that their foot is weak. They'll feel pain in the area, and that's when they present to us. So when we examine or clinically inspect the area, you'll see on the diseased side that the area is swollen. You'll lose the normal contours of the tendon. The area is typically bruised. And if you take your finger and rub it up and down the tendon with a little bit of gentle pressure, you'll feel a gap or a void. Now, that area can fill in with blood within a few days, so sometimes you have to push a little bit harder to identify the location of the tendon, but you can almost always feel it. The second most important thing that we do is a test called the Thompson test, or I call it the significant other test. Because if a patient is lying on their belly or kneeling on a chair, if you grab the normal calf of the normal side and you squeeze it, you'll see that foot plantar flex up and down. Whereas if you look at the injured side, you grab and squeeze the calf, the foot just lays there. It doesn't move at all. And we would call that a positive Thompson test because the continuity of the tendon has been disrupted. Because you might ask, don't I need an MRI? And the answer is no, you do not need an MRI. This is a clinical diagnosis. And studies have actually shown that patients that get an MRI actually have a delay to diagnosis or delay in treatment that can actually result in a worse outcome if the patient needs treatment for an Achilles tendon rupture. So let's talk about treatment for these three things. So the treatment for Achilles tendinitis and Achilles tendinosis is very similar. So if somebody presents with pain, we would have them avoid the aggravating activity that's causing the pain or symptoms for a period of time. They can use ice or heat, depending on what makes it feel the best, a course of anti-inflammatories if there's not a contraindication, and sometimes a period of immobilization with a cam walker boot, or if the symptoms are not that bad, sometimes even a heel wedge in the shoe to just elevate the heel and take the tension off of the Achilles tendon can help. Now, following that, either home physical therapy or formal physical therapy to work on stretching and strengthening can be helpful to resolve the symptoms. The other thing, which is more specific for Achilles tendinosis, the chronic condition, is if all of those things are tried and all of those things fail, we can do what's called an open debridement, where we actually incise the skin, open up the tendon where it is diseased, debride the diseased tissue, and then repair and close that area up and put them through a postoperative protocol. And the last injury that we're going to talk about treatment is the Achilles tendon rupture. So the Achilles tendon rupture basically has two options. You can either treat this conservatively or non-surgically, or we can treat it surgically. And both have two common risks. So there's a risk of re-rupture and there's a risk of weakness. Now the patients that are having non-surgical or conservative care, there's a slightly greater risk of re-rupture or weakness when compared to the surgical group. And who should have surgery really depends on a lot of factors. Age, there are studies that show that patients over the age of 40, there is no significant difference in surgical versus non-surgical care. But if someone's 45 and super active, they might choose to have surgical intervention. The other thing that we have to look at is patients' comorbidities or medical issues. So if somebody is a smoker or has vascular disease or is an uncontrolled diabetic and they're 38, that person has a much higher risk of complications, so non-surgical care might be safer. Because when we operate, things can happen. So the three biggest concerns that we worry about are a wound complication, where once you open up the skin, the wound itself does not heal, and it what's called gets necrotic or sloughs, and that can be a major problem. The other issue that we worry about is an infection in the area. And the third thing that we would worry about is a nerve injury, because when we go in there, we're opening up the skin, we're exposing the tendon, we're suturing part A and B and tying them together, and we want to make sure that that tendon is not injured. We also want to make sure there's not tension on the skin, which will allow it to heal without becoming necrotic or having a wound drainage problem, which can lead to an infection. And whether or not you have conservative or surgical care, the postoperative protocol is very similar, where you're put into either a boot, cast, or splint with the foot in a plantar flex position, and every few weeks that foot is brought back up closer to neutral or 90 degrees, and at some point your surgeon will then refer you to formal physical therapy, where you'll start with additional stretching and strengthening exercises. But it's a slow recovery. The tendon takes time to heal, and for many patients it can take 9 months to have a full and complete recovery. So I hope all of this information was helpful. If you're one of these people that's either dealing with tendinitis, tendinosis, or an acute Achilles tendon rupture. Until next time, I'm Adam Rosen. Thanks for watching. Stay safe.